Hi, this is Tammy McClush. Let's take a look at Section 5, Primary Radiologic Image. Now, when we are looking at how X-ray interacts with matter, we want to take into consideration what is happening to the primary X-ray beam. Now remember, when you are looking at the X-ray beam is going to start with the electron generation over at the X-ray tube cathode. Those electrons are going to go over and strike the X-ray tube anode on the target of the anode, and then come through the X-ray tube and down onto the patient and to the image receptor. Now the image receptors that we're going to be talking about are going to be either an X-ray cassette or a computerized radiography cassette or a digital imaging cassette. Now, a lot of the changes that you're going to see when you're looking at the radiographic image will only occur when you are taking X-rays with film. So if I'm talking about looking at the difference between the density, the contrast, you really can only see that with X-ray film. It's not very evident when you're taking a look at computerized radiography or if you're looking at digital radiography. A lot more is going to occur with the inability to see intricacies within the images when you're looking at digital and computerized radiography. Think of it this way. If you were looking at a movie on an old TV versus watching a movie on a brand new TV, you can see the difference. And that's what it all comes down to when we're looking at the different interactions and when we're viewing those interactions on the image that is provided to us for diagnostic purposes. So let's take a look at the basic interactions with matter, and in order to do that, we need to look at some terms. Penetrate means the ability to pass through an object. Think of shooting an arrow through the air, and you're trying to take that arrow and you're trying to hit the target. It's the same thing with electrons. Have we had the ability to have enough electrons to penetrate an object? So penetrability refers to the ability of X-rays to penetrate deeper in tissue. If you have a high energy X-ray, it is able to penetrate deeper in the tissue. The penetrability of an X-ray beam is called the X-ray quality. Now I'm going to be talking about quality quite a bit. You got to be careful when you use the term quality because it means a lot of different things. So when we're looking at the penetrability of the beam, it is the quality of the X-ray. Now when we're looking at the term absorb, absorb means to soak up. Absorption is an all or none condition for X-ray interaction. When X-rays are absorbed in the body, their energy is scattered or converted into new scatter X-rays. And what is scatter? It's when you throw something in various directions. Scatter radiation is X-rays that scatter back in the direction of the incident X-ray beam. When X-rays completely penetrate the body, there is no interaction with the matter and no scatter or scattered radiation is formed as a result. Now, I know this is very difficult. There's a lot of terms here, but what I also want to do is I want to take a look at the images on the screen. So in the very first image, you see that the electrons moved over from the cathode to the anode, and they were able to come through the X-ray tube as photons of X radiation. And think of this step wedge that we're seeing in the picture as a foot. So if this is a patient's foot, we're going to have different intensities across the foot because of the fact that the foot has different thicknesses. So depending upon the level of intensity we have in the beam, it will show us if we have the ability to capture all of the steps in the step wedge. So this is something that's very important to think about. How can we control the penetration of the beam, the absorption of the beam, and the scatter of the beam? Another term we're going to take a look at is differential attenuation. But before we do that, let's take a look at the word attenuation. Attenuation is the total reduction in the number of X-rays remaining in an X-ray beam after penetration through a given thickness of tissue. When a broad beam of X-rays is incident of any tissue, some of the X-rays are absorbed and some are scattered. The result is a reduction in the number of X-rays, which is a condition known as X-ray attenuation. X-rays can penetrate matter that is opaque to light. The penetration is differential depending on the mass density and the thickness of the matter. So I know that's a lot of different definitions for you, but you need to know the definitions in order to understand what is going on here. Now in the first picture, you see the primary beam is coming in, and then we're putting something in front of the beam to decrease what is able to appear on the other side of the X-ray beam. Think of it as the patient that is standing here, and this is a child that is standing here. Now remember, differential absorption means that we are going to have differences in absorption of the primary beam dependent upon what the beam is passing through. Think of an ultrasound. If we are sending a sound beam through water and it hits a submarine, it's going to be attenuated where we see the submarine. That's no different than when a lady goes in for an ultrasound to check the baby. When the sound goes through the lady's abdomen, it strikes the baby, and where we strike the baby, we're going to see an attenuation of the beam on our monitor. It's the same thing here. So when I'm looking at this radiograph of this patient, you can see that this person has swallowed the purple dinosaur Barney. I know it's hard to tell because the dinosaur looks white in this picture. That's because the plastic toy that this child swallowed is absorbing the beam, and that's why it looks bright white on the X-ray. So this is something to keep in mind when you're X-raying a patient. What is happening when I have different body parts in front of the beam, and how is the X-ray going to look because of this situation? You need to think about your patient as a subject and what in their body is going to change the attenuation of the beam. Subject contrast is a component of radiographic contrast determined by the size, shape, and X-ray attenuating characteristics of the subject who is being examined and the X-ray of the X-ray and the energy of the X-ray beam. Subject contrast is the range and differences in the intensity of the X-ray beam after it exits the patient. And it is going to be affected by the KVP and the tissue density. So in this X-ray here, you see that unfortunately this patient has been shot in the wrist. You see the bullet fragments, and you can see that the bullet actually caused the wrist to fracture. Now, a lot of times where you see the bullet is not where it actually entered the patient. It is going to bounce off the bone and go somewhere else. So if I'm looking at the subject contrast of this patient, I can see that they have bone, they have soft tissue, and they have lead from the bullet. So there's different types of subject contrast here because of the fact that this patient has received a bullet wound. So let's take a look at the effects of air, bone, muscle, and fat. Now there's something that's called a Z number. You're not going to need to know the Z number for this GXMO test. That's what an X-ray tech would need to know, or an X-ray student. But just so you know, X-rays penetrate air very readily. X-ray just goes right through air. There's going to be less penetration of fat and even less of water, which is going to be about the same amount as muscle, but still less than bone. So the first x-ray you're seeing is a patient that is young. Young patients are going to have a lot of bowel gas. I could tell that this patient has small bone structure. But if I'm looking at the patient on the opposite side, I can see that their colon is very distended. And that's because this patient has a problem with their bowel. Now, when I'm looking at these two patients, I see that there's more air on the older patient than on the younger patient. And I also see that there's more fat on the older patient. So as you can see, the x-rays are going to look different depending upon the absorption as they penetrate through the patient. Let's take a look at intensity of the beam. Now, intensity is another term that's rather difficult to find if you're going through an x-ray textbook. I went through several x-ray textbooks until I found the term that had a definition that felt right to me. So intensity, the intensity of an x-ray beam or of any imaging system is measured in milligray in air. We used to say milliroentgen, and is called x-ray quantity. Another term that we also use is radiation exposure. So you can use the term intensity, quantity, and radiation exposure all interchangeably. They all mean the same thing. Now, what's going on with these x-rays? Well, there are some factors that affect the x-ray intensity or the quantity of the beam. The first thing that affects the intensity of the beam is milliamps per second. So let's take a look at this a couple different ways. The very first x-ray. Let's think of that x-ray as it was exposed as 50 kVp, and it was just a quarter of a second. It was hardly any exposure whatsoever. It was a very small MAS. The MAS was probably 0.25, and that's hardly any radiation to the foot. When we went ahead and we increased that radiation, so the MAS was 2 milliamps per second, you can see that there is definitely a nice quantity of the exposure. I have enough electrons in order to see the foot. So if you have too little electrons, you may not be able to see the image when you're looking at the radiograph. Now, this is going to happen more or less on an x-ray that is film screen. You're not really going to see this if you're looking at CR or DR. What you will see is a number that's going to change. Now, sometimes the manufacturers turn these numbers off, and I'm definitely going to go into that when I go over digital imaging and CR. But for now, know that, let's say that the first image was 0.25 MAS, and the second image was 2 MAS. I have more quantity of electrons, so my image is going to appear darker. So X-ray intensity, or the quantity, is proportional to the MAS, milliamps per second. X-ray intensity or quantity is proportional to the kVp squared. The more kVp I have, I increase my ability to penetrate through more steps in the step wedge. So if I am x-raying a patient, and if the very first x-ray is 70 kVp, and the second x-ray is 40 kVp, I'm not able to penetrate as much as I lower the kVp. Now, to be very honest with you, I like to keep the same kVp body part specific. So if I'm x-raying arms and legs, I may choose 55 kVp. If I'm x-raying the abdomen, I may choose 80 kVp. So that's something that I like to do. I like to keep my kVp constant, because in a few moments you're going to see that kVp definitely changes the contrast of your x-ray. Now let's take a look at x-ray intensity, or the quantity, as it is inversely proportional to the square of the distance from the source. This is called the inverse square law. Think of it this way. If I take a flashlight and I put it right up against the wall, and then I start to walk the flashlight away from the wall, the further I have that flashlight away from the wall, the intensity on the wall is not going to be as defined. It's the same thing for if I'm taking an x-ray of a patient. Let's think about it this way. I'm going to x-ray a patient's chest, and I'm going to put my tube 40 inches from the patient. And now I'm going to x-ray the patient, and I'm going to take my tube 72 inches away from the patient. If I don't change my x-ray technique, the intensity is going to be different. So the intensity is going to change the further I am with my x-ray tube away from the patient. So if I take an x-ray at 40 inches, and if I don't change my MAS, and I go to 72 inches, the image that I'm going to see is going to be much lighter compared to the original image. And then the final thing that is going to alter intensity, or the quantity, is filtration. When X-ray quantity will be reduced when filtration is added. Now, a filter could be a collimator. So if I collimate down toward the skin line, I'm definitely going to reduce the quantity of unwanted radiation that struck my patient. I'm also going to reduce the scatter radiation. So collimating up to the skin line is going to provide a filter that is going to reduce the quantity of electrons reaching the patient, and it's going to reduce the patient dose. Okay, now this is the most important part of this particular section: contrast. As you change the patient and the patient's body part, you're going to change the contrast. Now let's think about it this way. Back in the day when we all had black and white TVs, or if you have a black and white computer, you're going to see that it's either going to be very black and white, which is high contrast, or very gray, which is low contrast. Now, if I'm x-raying a patient, they will have something that is called subject contrast that I just have to work around. And because of that, for a hand x-ray, I use a certain kVp. For a belly x-ray, I use a certain kVp. And for a chest x-ray, I do also. And that's because of the fact that kVp and contrast work very well together. And sometimes I got to be careful that I'm using the appropriate kVp for the body part that I'm imaging. So if I'm x-raying an extremity, an arm or a leg, when I am x-raying an extremity, the patient only has soft tissue and bone. That is it. There ain't nothing else. Soft tissue, bone. Maybe some fluid. Here you can see the patient has a fracture. They have a fracture of their fourth metacarpal. But all they have is soft tissue and bone. So to provide an adequate image, you are going to need to select a kVp that is going to give you a short scale of contrast to image the bone and soft tissue. So you want to select 50 to 69 kVp. Low kVp will provide high contrast, which is short scale. Low kVp, high contrast, short scale. The middle picture is an abdomen. In an abdomen, you have organs, you have air, you have fluid, you have bowel. The patient just has low contrast in their belly. Lots and lots of low contrast. So to provide an adequate image, you need to make sure that you select a KVP that represents a short scale of contrast, just like the hand, that can be used in abdominal structures. So 75 to 90 KVP is where you want to be for an abdomen, because low KVP gives you high contrast, which is short scale. Now the last picture is a chest x-ray. You're going to be x-raying lung, ribs, heart, mediastinum. These patients have very high subject contrast. So to provide an adequate image, you want to make sure you select a KVP that represents a long scale of contrast so you can see all the chest structures. So you want to go from 100 to 120 KVP. High KVP will give you low contrast, and low contrast is very long scale. Okay, I know that was a lot of information, but hopefully if you don't understand it, you can go back and review or continue, and maybe something will make sense as you go through the rest of these modules.